Next of Kin pays its respects to our oldest and greatest storytellers, the traditional owners of land and waters that this podcast is recorded on. Hello and welcome to another episode of Next of Kin. My name is Casey Beros and my mission is to give all of us as long as humanly possible with the people that we love most. I've spent my career almost 20 years helping clinicians communicate science to consumers. And I've been very lucky to work with some of the best experts in the country and also from around the world. So I'm well versed in what makes a great expert. But an expert with a story, they are my favourite. And today I'm joined by Dr. MICHELA Sorensen. She's a GP, she's based in Sydney, but she grew up in the country. In this chat, we talk through bits of Australia's healthcare system and how primary care, so when you need to go and see a GP, for example, just wasn't set up for the modern day, and a lot of it isn't working. We also explore the fact that we are both members of a really crappy club that we'll call the Lost Parents Club. And we talk through how MICHELA losing her mum shaped the way she treats her patients today. We also got really tactical and talked through the concept of defense and offense players in your healthcare strategy. And we talked through how MICHELA made it through her own dance with cancer. This is one of the most important conversations I will ever deliver because you are the best advocate your health is ever going to have. And I can promise you in 1 hour from now, once you finish listening to this, you're going to have some tools and strategies to empower you in that role and to make sure that you and the people that you love will live longer, happier, healthier lives. So without further ado, let me introduce you to Dr. MICHELA Sorensen. Hello, my love. How are you?
I'm good, thank you. How are you?
I'm good. Tell me, what's it like to be a GP in Australia right now?
Oh, great question. It's damn tough. It is really, really tough. And look, I'm going to preface this by saying I'm one of those really fortunate people that actually loves my job. Hand on heart, if I had my time again, I would do the exact same thing. I absolutely love it and it energizes me and I love the people I meet and I love my patient base and I love what I get to do with them and what I get to be for them. But it's damn hard. Everyone knows the waiting list times are through the roof. Trying to get an appointment with your GP is really hard. When you do, you often feel rushed because they're just inundated and also just really unsupported at the moment. So it's tough.
I've heard you describe yourself, and many GPs describe themselves as a jack of all trades and a master of none. But from where I sit, you kind of have to be a jack of all trades and master of all of them. Because what comes through your door, particularly over COVID, I think has really brought into focus the fact that you are not just GPs, you are acting as a psychologist. I know that a huge proportion of your time is spent counseling people who are just struggling mentally, physically, spiritually, emotionally. That has to take a toll on you, does it?
100% does, and it's one of those things you have to develop a really good emotional on-off switch. And, you don't want to be disconnected from your patients. You want to be there and you want to be able to give them as much of you as you possibly can. But also at the same time, you need to have a bit of a veneer. You can't take all of that on because it will absolutely break you. And you're right, I do say jack of all trades, master of none, but the difficulty is people expect you to be the master of everything, as you said. And the other difficulty is a lot of people actually just can't get in to see specialists, and that might be that there's no specialists around or they can't afford it. The other benefit our specialist colleagues have is that they often have a little referral letter with a bit of an idea of what's coming through their door, the benefit of they've had some blood tests that they can see already and they've had a scan result. We've got no damn idea. Like we just open the door and we don't know if someone's coming in for their cervical screening test or some routine blood to tell us that their marriage has just broken down or that they've just got a terminal cancer diagnosis. We've got no damn idea. And we've only got 15 minutes with them to try and work that out and also not just sort out all the medical stuff, but sort out that personal stuff and be there for them and allow them to ask their questions and allow them to unravel in front of us. And it's tough. Like I said, I love it, but it's exhausting. I come home at the end of the day and I might have seen 30 patients And I look at my gorgeous family and I'm like, oh, I love you, but I have no words left. I'm spent. I flop down on the couch and I'm done. So yeah, it takes its toll.
You know, I usually save audience questions for the end in these chats, but I think this is exactly the right time to raise a couple that came my way when I said that I was going to be interviewing you today. And one of them was, is it too much to expect a GP to have reviewed your file before you come in for your appointment? And I thought that was such an important question, because I think that there is an expectation that any doctor would have reviewed your file before you get there. But from what I understand of the work that you do, there is no buffer. There is no time for you to be able to do that. So the file is there for you to add that day's notes and dip back into if there's something that you need to check. Did we test for something? What were the results of that? But is it too great an expectation to have reviewed a file before you see a patient?
Yeah, well, look, and if I can just start these statistics by just giving you a bit of an outline for what our schedule is. For instance, me, start my first patient 8:15, 8:30, and usually I've got into work an hour early to check all of my results that came through overnight, make quick phone calls to patients or specialists for things that I needed to sort out. Then literally from 8:30 until 1 p.m, I've got patients booked in every 15 minutes. No gap, there's no overlap, there's not even a 2-minute interval between patients. So one appointment, say, takes 17 minutes, then I'm a few minutes late for the next patient. Next patient takes 20 minutes, then I'm a few minutes late. That doesn't account for even just, the logistics of opening a file, of typing things in, of printing things, of doing what you need to. So there really isn't that buffer. And often, we'll have that hour lunch break, which most of the time, for instance, Friday, for example, I was running late and it meant I had 7 minutes to run up, go to the loo, grab my lunch, quickly scoff down something before my next patient was already in the waiting room. So there is no time. But in saying that, I think most GPs will open a patient file, will have a quick glance through, we'll have a look at the previous appointment to see what that was about, have a look to see if there's any blood tests that need to be discussed or something like that. But we can't have gone through every bit of correspondence, every note that's been written. That would take hours, and it's just not possible, particularly when you think of 30 people in a day to actually have time to do that. You just can't. So we should have a bit of an idea of the general stuff that's going on now, but you just can't know all the ins and outs.
Which really begs the question as to whether or not the system is structured to support you and therefore us appropriately. So if you're remunerated for your 15-minute appointment from Medicare through the Medicare system, but then also potentially for a gap from the patient, whether or not you're bulk billing or you're not, or you're going to a bulk billing practice or you're not, the system is almost designed to fail. There is no buffer for time. There is no buffer for you to be remunerated for that time to check. And as you say, we're so under the pump in terms of the need, the demand for GPs full stop, let alone good ones. And I could wax lyrical for hours about what makes a good one and the importance of finding one that you trust, that you like. You have to like them. These people know the most intimate details of your life. Good GPs are hard to find. It has not been a sexy specialty. It has not been, where a lot of people have been drawn to over the years. And I think that that's changing now, and we're certainly pouring more resources into getting more GPs in. But do you feel like the system is designed to support you? Because one of the other questions that came through from the audience was, why can't all GPs bulk bill? And I think it's a fair question.
Absolutely. And look, the system is designed for people to have a regular GP that they see. They don't see anyone else. That's their GP. It's set up back in the day when there was one GP per town, per little community, per suburb, and that was where you went. Whereas that's not how it's structured now. And they're big centres and people often go in and they'll see whatever doctor they can see, or, they might have to go to multiple different centres depending on who's got appointments on the day. And that's where it's set up to fail, because you get that fragmentation of care. There's no sharing of notes, or even if you're at the same clinic, that all the different doctors don't have time. And often people say, but I just feel like I'm doing the same thing over and over again. I'm having to tell my story over and over again. And that's not a criticism of the person seeing different people or different doctors, because, that's just the nature of the system at the moment. But it's just, there's a disconnect between how it was set up or when it was set up many moons ago to how general practice is set up now, and the two just don't line up, unfortunately. And look, we would love to all bulk bill. We 100% would love to, but the issue is if we were to bulk bill, you wouldn't even be able to pay your rent at the clinic. Gone are the days where even for GPs now, you find very few of them that actually own their own clinic, because what you get remunerated by Medicare isn't enough to cover costs, that the running costs of the clinic isn't enough to cover the nurses, the receptionists, the insurances, all of that. And that's why so many practices now have been bought out by big corporate companies where, they can mass scale everything, which always makes it more economical, because Medicare just doesn't cover it. And the other thing is, there was this expectation that general practice, seeing your doctor should always be free. But when Medicare was first founded, 50 years ago, it was never designed to be a free service. It was designed to compensate the patient for their costs in seeing a doctor. It wasn't designed to be a pay for the doctor. It was designed to be a compensation for the individual. But then with the rise of these mass bulk billing clinics in sort of the 80s and 90s, that skewed everyone's perspective, and everyone thought all of a sudden, no, that's paying the doctors and we shouldn't have to pay anything. But that's not how it was set up. Most people don't bat an eyelid about having to pay to see their dermatologist or their cardiologist or their oncologist or whatever it might be, yet to fork out to see their GP, they don't want to pay. And like I said, I would love to be able to, the whole system would be bulk billing, but then we would have something that's probably similar structure to the NHS, where you do have waiting lists of, 12, 18 months to get anything done, if not even longer. And you don't get a choice in what doctor you see. You've got one clinic that's in your area, and that's the clinic you have to see. You can't go beyond that. The waiting list to see GPs are 3, 4, 5 weeks. So there's always going to be flaws in the system. And I don't have the solution for the perfect system. If I did, I think I'd be something other than general practice, and I'd be sitting there in Canberra putting my 2 cents worth in. Basically, just as something needs to change. And that's both from a structural but also a societal perception, I think.
Definitely. And, I think we hear a lot in the media about these Scandinavian countries that are the happiest countries in the world. And we liken that to, well, they get free education, they get free healthcare. And in essence, I think that there's a misunderstanding that Medicare is free healthcare. And in some senses it is, right? You can go to a public hospital and get treated at a public hospital for free. And there are bulk billing GP clinics where you can be seen for free. Again, you'll have long wait times for anything that's specialist related or any surgery or anything like that. But I do think that we as consumers, as patients, we need to bump up our own advocacy. And that's what Next of Kin is all about. Next of Kin and patients are the two parties that are most invested in better outcomes. And we don't expect to own a home and not pay council rates. We don't expect to drive a car and not pay motor vehicle registration rates and licensing rates and to get our car serviced. Yet when it comes to our healthcare, there is an expectation that it should be free. And I think when it is free, there is a acceptance of a lesser standard of care. That I will go to the big bulk billing super clinic because it means that I can run in, get that script from a doctor that I've never seen before and will probably never see again, but that's all I need. It's just a quick visit. It's not complex until I get to the end of the appointment. And then I mention that funny spot on my back as the last thing that I was going to talk about that actually was the most important thing that I needed to see the doctor about that day. And as you said, the fragmentation of the system and the non-continuation of care, people are suffering as a result of that. And they're particularly suffering, and this is something that I know that you and I are both passionate about, is the country. So regional, rural, remote people who live in those regions do fare more poorly. If you look at any of the data, their outcomes are worse than people are living in the city. And part of that is about access to care, but part of that is about patient education, and people don't know what they don't know, right? And they might have to drive 3 hours to see a GP. There might be a 2-month wait list for the GP who is in their area, let alone specialist care. So we've got a big job on our hands to kind of help close the gap. How does that feel for you as somebody who grew up in the country? That was your experience. It's part of what made you want to go into becoming a doctor. What does that feel like for you to know that those gaps exist? And do you feel frustrated that as one little person in a big, broken system, do you feel like your hands are tied a little bit in terms of what you can do about that?
Yeah, absolutely. And I think there's so many elements to this. And yes, I feel it breaks my heart that that's still the situation. I mean, my family all still live in the country, and more often than not, there's not a local GP. And when they do have to travel into the big town to try and find a GP, again, they've either got closed books. If they do have open books, it's a couple of month wait. And again, it's a whole day trip for them just to see the doctor because they have to travel so far, wait, have their appointment, drive home. It's really, really hard. And so I had all these dreams of being a country GP and setting up a clinic there and thinking that I'd be able to, at least while I could put a doctor in every town, I could at least address the issue in one small town. But, then I found myself working in the eastern suburbs of Sydney, and I feel quite hypocritical with that. And it's something that I guess I'm conflicted about on a daily basis. But like so many doctors, like so many other professionals, the difficulty is it's then setting up your family in that area and, where would my husband work? Where would my kids go to school? Well, all of that stuff they put so many limitations on this. And, for a lot of doctors, what limits them, because, the incentives are there, the remuneration's there, but it's the thought of being a solo town GP, being on call 24/7, having no specialist services around, having limited hospital supports. I enjoy the fact that general practice gives me a work-life balance. I can work part-time. I can still be a mum for my kids. And I think there is a bit of a belief that if you were to go rurally where they're very much in need, you wouldn't have that option and you'd be worked to the ground. And look, they are trying to change that. And I know there's a lot of small country towns that are trying to push for job sharing doctors and getting multiple doctors. But again, that's hard. If you can't get one doctor, how do you expect to get three? So I think there's lots of issues there, but yeah, it's damn hard. And can I just circle back really quickly at the sake of backtracking to what you said about Scandinavian countries? And so many people bring that up to me in clinic, like, why can't we do it like they do in Denmark or Sweden where everything's free? But look, my family are Danish, and what a lot of people don't realise, they're paying 64 cents in the dollar tax. So if all of a sudden our government were to say we're going to jump up our top tax bracket to 64 cents, I don't think people would be too happy. So you can't have your cake and eat it too. Like you've got to there's a bit of compromise. And if we compare our public system to the rest of the world relative for what our health budget is, it's pretty damn good. If we look at someone that's got a potential cancer diagnosis, they will be seen quickly. They'll be seen within, depending on what type of cancer it is and where they're living, within a couple of weeks. They'll have all of the options for care, and our public health system does that really, really well. It's just the difficulty is that grassroots. It's the general practice where we're really struggling in terms of getting the access.
We really need to reimagine the entire system. And I just went through the public system with my dad. He was diagnosed with mesothelioma. It's a relatively rare but very aggressive, fatal, terminal, incurable cancer. And I have to say the public system was wonderful, but it also left a lot to be desired. I think that there's a bit of a misunderstanding. There certainly was for me, and I've sat on the periphery of the healthcare system for my entire career. Almost 20 years I've been working and reporting on the system. And I think I thought that if you ever got an awful diagnosis, and I have always had private health insurance. That's not something that my dad chose to do. I've always had private health insurance because I've always operated under the assumption that if the shit hit the fan, that I would have choices as to how and where I received my care. That's always been my thinking. Dad didn't have that, but because of his diagnosis, he was ushered into the public healthcare system, and they did do a wonderful job of, in a very fragmented, siloed way, delivering the appropriate, I'm going to call them plugins of diagnosis, of treatment, of management and of care, and eventually of death to be able to take us through that system. But again, had he not had me, I remember him saying to me something like, I just feel like no one's got me. I feel like no one's in charge. And I think that that's a real misunderstanding, that people think that they're going to get put into a system like that and that there's somebody's going to be in charge. And often that falls to either a family member, like it was in our situation, or back to the GP. You're this touch point that they bounce back and forth. I remember being at the hospital with Dad and trying to get him a referral for, he had a symptom that was outside of the scope of what they could do in oncology or radiology, and them saying, okay, now you need to go back to your GP to get a referral to that specialist. And I was like, but we're at the hospital. You have those specialists here. Why does he have to go back to his GP? That just made no sense to me. It's like, isn't that then putting more burden on GPs? And his GP happened to retire in the middle of this experience, which he is absolutely entitled to retire. The guy has worked long and hard for decades to get to that. So I'm like, of course. And then my job was to find Dad another GP and download all of that. Like, you're so lost. And if you're not well enough to be able to navigate, you have to have somebody that's riding shotgun with you, don't you?
Yeah, absolutely. And this is the other thing, though, again, what you said before, you don't know what you don't know. And if you don't know anything about the system, you can't navigate it and you can't advocate for yourself. You don't know what questions to ask. You don't know who should be doing what and where to be sitting at this point in time and where to be asking for this. And that's where it comes down, because most people aren't in a position like you or I where we are health literate and we've been in the system. Most people have no damn idea. And, even I talk about it with my husband all the time. He's like, I've got no idea. I go to a doctor's appointment. I don't know whether it's Medicare. I don't know whether it's private health. I just put all my cards on the table. I don't know how much it's going to cost me. I don't know how long I'm going to be there for. I don't know. I don't know when I need a referral or I don't. And again, that's where the GP is so, so important. And I say this to so many of my patients that have got chronic illness or have got lots of different people involved in their care. And I'm like, look, as a GP, I don't know as much as your specialists do about each individual thing, and they're the ones that are going to be leading a lot of the management. But see me like you're kind of your builder or your project manager, and I'll just be the one that communicates between everyone, ensures we're all on the same page, and just kind of fills those gaps. And that is such an important role. Like, again, go back to the analogy of a builder. If you're building a house, trying to liaise with a plumber and an electrician and a tiler and a concreter is damn hard, and that's why you pay a builder. It's the same thing with your GP. It's so important to have someone and checking in with them regularly. And I know that can be really hard, as when you're caught up in that system and you feel like you're spending your whole time at the hospital and constantly having tests and different appointments and stuff. But it's so important to be still checking with your GP so they're in the loop, because being on the other side as a GP, and I've been there as a patient myself, but as a GP, it's really, really difficult because often we don't even get correspondence from specialists and hospitals. And someone will come and sit here and say, oh, I just had an appointment with X, Y, and Z, and this is what's going on. But you should know they said they were going to write to you. And I'm sure at some point they will, but it can take months and months and months before we even get any correspondence. And that's really hard then to be able to advocate for you if we haven't been kept in the loop. So, again, just communication, talking and finding someone that you trust is so important.
So important. I think a lot about educating and empowering patients. That's why I exist. That's my mission, is to give people as long as humanly possible with the people that they love. That's my goal. I'm, as I said, deeply committed to kind of helping close those gaps. Do you think that they would listen if they were given the sort of rubrics that a doctor might use to quickly assess and potentially mitigate risk? So, for example, if you have symptom A as well as symptom B and C, there's a high likelihood that if we investigate that further, that there may be a diagnosis of cancer or heart disease. Our health doesn't really mean anything to us until we lose it. So do you think the patients would listen if we could get them the information?
Look, I think they would. I do think they'd listen. But in terms of whether that translates into action, we also then need to concurrently start addressing some of the issues we just spoke about, because it's all well and good for them to say, oh, look, I've actually got symptom A, B, and C. Shit, there's a high likelihood that I've got cancer. but I don't have a doctor I can get to. I can't get an appointment for 6 weeks. I have to take an entire day to get there and get back, and it's harvest or it's shearing season or it's whatever. The practicalities of that are a huge limit for a lot of people, or I don't drive, or I don't have this, or I don't have that. So I think people would listen, absolutely, but it's going to take a long time. Like with anything, it takes time to change, right? And we've got to start somewhere. So education is the first point, and that's where things like social media, podcasts, etc., are really, really helpful because it's so much more accessible for a lot of people. But it's then also finding reliable stuff that you can trust that tells you what you need to actually know. But like I said, it's all well and good to have the information. You still then also need the services and the supports and the structures around you too. And often it also takes having other people in your life that are health literate that are also going to push you out the door, because there's still that big mentality of, no, she'll be right. I'm right. Yeah, but I'm probably, it'll be fine. There's someone worse off than me. It's okay. It's probably not cancer because I'm not that tired, or I haven't lost that much weight, or there's only a little bit of blood. It's okay. So they're still shifting that mentality, which again takes time and takes often generations too.
And it's not just Farmer Joe and Farmer Tony that we're talking about there. I was at a girlfriend's house yesterday and she was having some symptoms almost 6 months ago, actually ended up in hospital, and there was written a referral for an MRI from a neurologist in the hospital system that she still now, 6 months later, has not had. And I went over there yesterday and I ask her every time we catch up, and I only see her every few weeks, so I'm not harping on her every couple of days. But every time I see her, I ask, have you had your scan yet? No, I haven't. Like, we're all guilty of having that pathology request or that specialist referral rattling around at the bottom of our bag, collecting dust with all of the hair lackeys and the piece of chewy and the lip balm that's lost its lid. And that scares me. I've always been such an overthinker that there's not a lot of room in my life to not go and get those tests as soon as I could get in, if not sooner. But just to double back to Farmer Joe and Farmer Tony, is that not the reason that telehealth exists? Like, we've been through this big horrific experience of COVID. Telehealth is one of the things that was put into place, and was put into place very quickly. I know it had existed for a long time before that, but we all got used to using it. So why can Farmer Joe and Farmer Tony not use telehealth? Let's say that they do go, right, okay, tick, tick, tick. I've got symptom A, B, and C. We get them the education. They know that. That means that there is a high likelihood that what they might be facing is a cancer diagnosis. But as you say, it's shearing season and there's a 6-week wait to see their GP and a 3-hour drive, which makes it a day's investment, and there's nobody to look after the farm. Why can't they utilize something like telehealth to be able to overcome the boundary, or the barrier rather, of time and distance?
Yes, so they certainly should be able to, but they also need a doctor at the other end of that telehealth screen. They need a doctor that's got an appointment. They need a doctor that's accepting new patients. And depending on where they live and what their classification is, without going into all the details of that, but there's still also some limitations around telehealth in that in order to access a Medicare rebate for your telehealth appointment, you need to have been seen physically in that clinic within the last 12 months, which for a lot of people, I know myself, it can be well over 12 months between my GP visits personally. And it doesn't mean whether they've been there with kids or with a wife or whatever. It's physically an appointment for themselves within the last 12 months. But like I said, the biggest rate limiting factor to that is actually having a general practice that you can go to, and a doctor at the other end of the screen that will accept new patients or have an appointment for you. That's the problem.
And that means time on the phone. Get online, find a number of clinics or practices that are, close enough that you could drive if you needed to, or you could get there in some way. And then picking up the phone and calling them one by one and going, do you have any doctors that have openings at the moment? When is the next appointment? But yeah, God, that just seems like a real flaw in the system.
It's an issue. There's always an excuse, and we can always make excuses for why we don't do things, and it's too hard and there's too many limitations. But at the end of the day, this goes back to one of the first things you said. It's us taking some ownership and some accountability as well. And it's like anything in life, there's always barriers, there's always challenges. But if we want to be here for a long time, for ourselves, for our family, for our whatever our reason might be, we also need to be a bit accountable. It's like walk into the supermarket and you're like, oh, it's just so easy to just buy the chocolate and chips because they're just there and at the end of the aisle and I can't be bothered going and thinking of all the stuff I need to buy to cook and the fresh fruit and veg and it's more expensive and blah. Again, excuse. And I know that's the reality for a lot of people in life is bloody hard. But at some point we also do need to take ownership.
It really blows my mind that in this country, and I don't know this to be true from the data, but I don't think it's much of a stretch to assume that if you're living in any developed country, that you are most likely to die from a preventable disease. So heart disease, cancer, neurodegenerative diseases like dementia or Alzheimer's, type 2 diabetes, related metabolic disease, cerebrovascular, so brain diseases like stroke. Why? Like, I know it to be true that there are different demographics within society. And I also know that my biased lens lives in a relatively affluent area where people, the majority of people, invest in doing some exercise and staying relatively connected to their people and not drinking too much alcohol and listening to a podcast like this or any of the others out there, because performing at a high level, so earning well, living well, loving well, is important to those people. And I also understand that if you drive out to many, in fact, the vast majority of the rest of this country, that life is not like that there. So I say this with the greatest love and respect to the psychosocial element that contribute to this broader picture. But it is mind-boggling to me that the vast majority of us will die from a disease that by and large we can prevent. Do you share that sentiment?
Absolutely. And there is just one little caveat to that. I mean, that does confound things a bit in that because we are getting so much better at treating things like infections, like gastros, previously the biggest cause of death was, infective gastroenteritis, which, in third world nations in Africa, in Uganda and countries like that where I worked for a period of time, that was the biggest killer and people's life expectancy was 49, still is around 49. And that's because the vast majority of them are getting things like malaria or getting things like, cholera, etc. In Australia, we're so privileged that we have access to healthcare that can treat these things. So people are living longer, which means there is a higher likelihood that we're then going to get lifestyle-related illnesses like diabetes, like heart disease, like cerebrovascular disease, like different cancers, because that's a byproduct of aging. So that's one side of it. But 100% right in terms of the differences in demographics and why we get such higher rates of these lifestyle preventable diseases in regional and lower socioeconomic areas. It's bloody hard. And it is an absolute privilege to have access to information, to have access to gym memberships, to have access to healthy food, to have the time to be able to look after yourself is a privilege.
Yeah, agreed.
And I, like you, am fortunate that I live and work in areas where that is the demographic. However, you're a single mum working 3 jobs just to put food on the table. You're trying to get your kids to school. You're trying to run them around on weekends for what they need. You don't have time to go and do a shop and buy fresh fruit and veggies every few days and cook huge big meals. You do what you can to survive. Mm-hmm. And if you are struggling with depression, well, the last thing you feel like doing is going out and going for a walk or a run or a swim. And even though you know you should, depression doesn't allow you to do that. It also doesn't allow you to put nutritious food in your mouth. It doesn't allow you to sleep the amount you need to sleep. So there's a huge, it's hard. They're often all of these, once you start getting one lifestyle illness, all the others tend to compound on top as well. And when you have diabetes, often then you're overweight, which makes exercise harder, which then means you get high blood pressure and have a heart attack. And it all feeds into one another.
I have been thinking about our health in terms of, a football team or a basketball team. And we have a defense side of the team. So in public health, we would talk about risk factors like not moving enough, eating a non-nutritious diet, smoking, sitting too much, being overweight or obese. And then you also have the offense side, right? The prevention side of healthcare. And I'd just love to hear you talk about what are your kind of non-negotiable, what are your MVPs of the things to avoid So the risk factors and the things to do to help us prevent having to fight fires in the first place.
None of this is groundbreaking or revolutionary. It's stuff that we all probably know we should do. The non-negotiables for looking after yourself, it's sleep. Sleep is so important, and it's something that we're all, as we get older, pretty bad at, whether that's due to stress, whether it's due to technology, and a whole range of different things. But sleep, it's when your body, yes, it's a restful state, but it's actually a really active state for your body. It's when it regenerates, it repairs cells, it fights free radicals, it heals, so it's so, so important. So sleep's a non-negotiable. Eating well. And again, this varies from person to person what it looks like. I'm not saying you've got to live off steamed greens and salad and things all day, every day, but it's making sure that vast majority of your meals contain nutrient-dense fruit and veggies, and they don't have to be fresh. They can be frozen depending on what your access is, but you're eating protein, you're eating a whole range of different food. And a lot of people think they're eating really well, but they eat a really narrow subset of foods, and it's the same day in, day out. That's actually not great for your health either. Your body needs a range of nutrients, a range of different foods to help support it. Not smoking is key. Minimizing alcohol. I'm never going to sit here and say never have alcohol ever. Some people, alcohol doesn't agree with them and they shouldn't have any, but I like my glass of wine on a Friday night. But it's again in moderation. So alcohol in moderation. And movement's the other key. And again, you don't have to go run for a marathon. I think there's this mindset of I either need to be like an elite athlete, but if I'm not that, I may as well just do nothing. But just gentle movement, stretching for half an hour each day, or it's going to have huge benefits. We know, for instance, steps. Let's talk about steps. We've got this goal of 10,000 steps, which, by the way, we actually don't even know where that came from. There's no science behind this magic 10,000 step mark. I think it was just a marketing tool.
It's a lovely round number.
Exactly, which we all love in life. But a 20% increase in your steps that you would normally do from your baseline can actually have huge health benefits. So if you normally say only get 3,000 steps in a day, if you can get that up to, now my maths isn't very good, but 3,500, 4,000 steps, that will have health benefits. Or if you normally do 5,000 steps, trying to get that up to 6,000 will have health benefits. There was a really interesting study that came out last year, and it showed doing, that exercise where you sit against a wall and you get the quad burn. Doing that for 7 minutes a day, which 7 minutes is a long wall sit, by the way. I don't think my quads could do that, but let's just say you break it up and you do 30-second rounds. But that lowers your blood pressure by 20 points. If you do that regularly over 6 months, people's blood pressure was lowering. So it doesn't have to be huge things. You can just do it at home, and you don't need an hour. Because again, if someone says to me, you need to exercise for an hour every day, God, no. I've got 2 kids. I've got 2 toddlers. I work. There's no chance. But if you can do little 2-minute stints, which most of us can find 10 minutes, then that works. And I'll often say to people, if you drive to work or you catch a bus, get off a stop earlier, or park your car, and before you walk into work, literally just walk around the block. Just one little walk around the block, 5 minutes. Do it again before you get in the car to leave. And then when you get home, say you're cooking dinner, do 10 minutes of squats and whatever, just gentle movement. And those little things all add up.
There's some research out of Harvard that I was just hearing the other day, and the doctor's name escapes me, but he was talking about the business term minimum viable product, and they talked about minimum viable intervention. And he was saying that for exercise, what they've started to find is that it's about 45 seconds. And so it could be 45 seconds of squats while you're waiting for your toast to toast, or while you're waiting for the kettle to boil. Like it can be anything, but just do something.
Yeah. And then the other thing is seeing your doctor when you're well. So you actually have time to do a general health check, to check in with what your blood pressure is doing, when you last had blood tests, what cancer screening tests you might be due for, whatever you might need, because it's really hard to fit that into a 15-minute appointment when you've got 7 other things on your list that you need to do. So actually making an appointment when you're well so that you can put your offensive tactic, going back to your analogy there of a football team, put your offensive tactic in play so that you've got direction and you're not always fighting fires.
Agree. I want to switch gears. You and I are both part of a really crap club, which is the Lost Parents Club. Tell me a little bit about your mama and how she shaped you.
Yeah. So look, and as cliched as it sounds, mum was my best friend. We did everything together, and she was kind of like that cool mum. My friends would come over to visit her even when I wasn't at home. And we grew up in little country towns. We moved around a fair bit growing up with Dad's work, and she just kind of had odd jobs here or there. But I always think back to when I was at high school and she worked in the local bank. You know, there'd be 5 or 6 bank tellers. That was, you know, back in the day when you had bank tellers and you'd go in to get your money out. And they'd all be like free and they're going, next please, next please. There would be a line out the door, and they were usually all teenagers, like all my mates or the boys from football or whatever. And we go, next please, and they'd be standing there going, no, we're just waiting to see Jules up. I'm just waiting to see Jules. Like, she was that person. And it's funny because she never liked being the centre of attention, and she was never someone that liked to draw attention to herself. But she was also that person that would walk in a room and everyone knew her and everyone instantly felt like they were her best friend. And she was my biggest champion and cheerleader. Like, I was always just as much as a very quite anal, quite perfectionistic, and I'd push myself nonstop. But she would always, all through my school life, the day before exams, wouldn't let me study at all. We'd close my books and say, come on, we're going out. And she'd take me, we'd go shopping, we'd go and have coffee and cake, we'd go and get her hair done, because she knew me better than anyone, and she knew that if I just kept pushing myself, I was that prepared. I'd been preparing for 12 months for this exam before I even knew it existed. I just needed time, and she was that person. And then obviously she was ecstatic when I got into medicine, but I'd be sitting there, I remember first year uni, and I hadn't studied biology or chemistry, so I've got into medicine and I'm doing physiology lectures going, oh my God, they may as well be speaking a foreign language. Like, I've got no idea. So I'd sit there and I'd study for 12 hours a day without taking a break. And Mum would knock on my door and go, sure, this is what you want to be doing. You know, you wouldn't be disappointed if you're a bus driver, that you can do whatever you want. You don't have to do this. So, you know, she was pretty bloody incredible.
Oh, MICHELA. She sounds like such a legend. She was 49 when she passed. You were a baby, you were 20. And when you and I spoke in our pre-interview, you shared with me that you were only in your second year of medicine when she passed. And now looking back, you can see some of the frustrations that we have shared in this chat so far about a system that kind of let her down. Can you tell me what happened?
Yeah, absolutely. And it's actually interesting you say that your dad's GP retired in the midst of his diagnosis and treatment. Same thing happened to my mum. And my mum was pretty quick. She was 9 months from diagnosis to when she passed away. So she had stomach cancer, which, as we all know, has a pretty bad prognosis. It's up there with sort of pancreatic cancer. And the reason is it's because it's always diagnosed late, because the symptoms are really minimal or non-specific until it gets bad. But she'd had reflux for about 3 years. And look, I say all this not as a criticism to her GP at all, and I know I'll find myself in a similar situation one day, but she'd go in and she'd say she had reflux, and the GP would give her a medication and she'd go home and take it and it didn't work, and then she'd go back and then they'd give her another medication and it wouldn't work. And this went on for about 3 years, but it got to a point where Mum's like, oh, stuff it, I'm just not even going to go anymore, because I sit there and take time off work to go and see the doctor. I sit there for a couple of hours and then they give me something that doesn't work and nothing gets done. So whatever it is, what it is, I'll just live with it. Anyway, it got to the point where she actually physically couldn't eat. And then eventually they referred her for an endoscopy, so where they put the camera down to have a look in. And that was, like I said, 3 years of uncontrolled symptoms. And by the time that she got to have her endoscopy, they couldn't even actually get the camera into her stomach because the whole thing was just a tumour. So needless to say, did that. So she went through, she had major surgery to remove her entire stomach and part of her small bowel. Then she had chemotherapy. But within 6 weeks of that, its metastases started to pop up and they were sort of all through her bones and everything. And again, it was from when she finished her chemo to then getting the metastatic diagnosis was her GP had retired. So she was just sort of seeing this new GP for the first time, who happened to be a GP that I'd done a medical placement with. So the poor man was sitting there, having never met my mum, but having met me before, having to tell her that, you know, things are not great. But then we're forever grateful to another beautiful GP who had closed his books and was not taking on new patients. But we happened to have a mutual friend who spoke to him about our situation, and he took Mum on, and he was incredible and guided mum, but more so our family. Sorry, I'm getting emotional, but I said this would happen. Guided our family through the whole process. So his empathy and his warmth is something that I guess has also hopefully shaped the way I practice.
Well, you never forget somebody like that, right? In a moment of complete darkness where someone has just switched off the lights and you're like, my torch isn't working. I don't know where I am in the system. I remember my dad saying to me, like, I'm terrified. I'm really frightened here. And that is such I was going to use the word burden. That's not right. But such a weight to hold space for somebody going through that journey. I did it at 39, 37 to 39. I cannot imagine going through that at 20. You were a baby. I'm so sorry that was your experience. I'm so sorry.
And look, it's one of those things that it's quite funny because my mum was the exact opposite, which is also probably how I am today, in that she went into control mode. She's like, I think she knew, and she'd been suffering for a long time. And she was like, no, I'm not scared anymore. I'm ready. Like, I'm not scared. And she used to always, pre-getting sick, she always say, God, I'm scared of dying. Like, that thought petrified me. And I remember asking her when we knew that she was getting towards the end, and she's like, no, I'm not scared anymore. I'm not scared. I'm ready. But I have to laugh because she passed away in the October and she had all of Christmas sorted. She had made sure that I had to go and buy all the Christmas presents and come and show her, so she knew what everyone was getting and who was, what was being sorted. My 21st birthday was the following February. She made sure that was all sorted. She had the presents sorted. She had her entire funeral planned. She knew what coffin she wanted, what flowers she wanted. And I remember my dad really struggling with that. He's going, no, I don't want to talk about that now. And I had to sit him down and say, look, Dad, we have to let her do it. This is her way of coping and taking that burden. And I just, a funny little side note, I remember talking about it and going, oh, don't worry, Mum, I'll get you some make sure you've got nice clothes on and everything like that when you go in your coffin. And she said, what do you think I want to wear? And I said, oh, Mum, you'll want those Calvin Klein jeans. I know you'll want those. They're your favourite, and your favourite white shirt. I know you'll want that. I'll make sure you've got nice new underwear on, because Mum used to always say, doesn't matter how you look as long as your undies are clean and well paid for. That's the main thing. So, and then I said, and those brown boots, your nice new brown boots that you love. She said, oh, no, Michaela, I'm not wearing those in a coffin. It's like, what? She was quite claustrophobic if you're wearing boots in a coffin. Besides, they're expensive. Your auntie can have those ones. So she was just right to the very end, just pragmatic and having a laugh. And, that, again, was her way of coping, but she also knew it would make it easier for us as well.
Wow, what a woman. I often wonder what I would be like in that situation, and I'd like to think that I would be the same, that I would make things as easy on people. I think that's a real sign of love and respect, is when you want to leave everything as easy for the people that are not only grieving but trying to wrap up the administration and the physical evidence of a life. That's a huge weight for any family to carry. And I love those little moments of lightness in a really dark time. And Dad and I had so many of those, and you never forget them, right? Because they're these moments of, like, the humanity in that is just so beautiful. And the practicality of, country jewels is like, don't bury me in those boots. Those boots are too expensive. Make sure my sister gets them. Like, the generosity of spirit of that is so beautiful. And I obviously have never met Jules, but I wonder how much of her is in you. Were you similar?
Very much so. Very much. And look, to be fair, I think that's almost giving myself too much credit. I mean, if I could be half the woman she was, I'd be so, so proud.
Oh, I think she'd say the same about you.
Thank you. But I also laugh because my daughter, who's 3, is my mum reincarnated. I was probably, mum used to like to call it spirit. She had a bit of spirit about her. And that's definitely my daughter as well. She comes out with things and I just think, oh my God, that's my mum. That is my mum. So I think she lives on. She definitely lives on.
That's beautiful. She sure does. So fast forward like 14 years. And you find yourself in this very strange position of no longer being the doctor, but now becoming the patient. You go to the dentist. You're like, I'm killing it. I'm a new mum and I'm taking myself off to the dentist and tick, 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 adult star chart for self-care. Well done, Michaela. We've gone to the dentist. And the dentist says what?
Yeah, so and you're absolutely right. I was so proud of myself. My youngest was 2 months old. My husband had been off work for a few weeks, was about to go back to work. And I thought, I'll leave him at home with both kids. So I had 2 under 2 at that stage. Like, go get my teeth cleaned. It had been 12 months. Anyway, I sit down there and I'm chatting away to the dentist, who I'd also only met once before when I took my daughter for her first checkup a couple of months prior. And he looked in my mouth and he's checking my side, and then he just stopped and he was like, oh, there's something really unusual. And I remember he paused and he said unusual, and he was looking at it, and then it's like, have you noticed this big lump on the roof of your mouth? And again, this is that you kick yourself. You go, probably when I first fell pregnant with my youngest, Nick, so 9 months prior, I noticed a tiny little lump that I thought I'd just burnt the roof of my mouth. And I was like, it's probably just some weird pregnancy thing where it swells up because weird things happen in pregnancy and your gums get really sensitive and your tongue often gets inflamed. So I thought it's just that. And then I forgot about it because I had no other symptoms. Yes, obviously the lump persisted, but I couldn't feel it. I had no pain. Even when I would sit there and talk, I couldn't feel it. Anyway, needless to say, I didn't even end up getting the teeth cleaned because I got distracted by this massive lump that was on the roof of my mouth. It was also one of those moments where, so he did some scans and things, and then he said, look, go home, I'll call you at lunchtime when I've had a chance to look at these scans properly. And I was meant to be going straight from the dentist to catch up with a friend for a coffee who is a colleague of mine at work. And it's funny, she's one of those people that her and I, it takes us about 6 months to even tee up a time to catch up outside of work because life is busy. Mm-hmm. She'd text me the night before and I said, hey, are you free for a coffee tomorrow? Which never happens. And I was like, actually, I am. Sean can keep the kids, that's my husband, and I'll catch up with you for a coffee. So thankfully, again, the stars aligned. I went straight to her and I sat down. I said, look, I'm a bit distracted. This has just happened. And I showed her inside my mouth and she's like, right, sit here. And again, where I'm forever grateful to my colleagues, we phoned in some favours. A friend of ours who owns the radiology centre across the road from where we were having coffee scanned me on the spot. Some other friends of ours who work in head and neck cancer rang me and said, look, come and see me at the hospital tomorrow. I'll have a look at you, da-da-da-da-da. And anyway, a huge roller coaster of emotions. I remember driving home, you go into that practical organisation where you said, right, so you've got income protection, haven't you? And you've got this and you've got that. And we're just trying to sort things out. And then that night, the radiologist called me. The other surgeon I was seeing the following day called me, having looked at my scans. I'm like, Michaela, we think it's fine. Big, deep sigh of relief. We think it's fine. It's a cyst. It looks like a cyst. You've got this weird wisdom tooth growing in an odd direction. You've got a cyst around it. And they'd had multiple specialists look at the scans. So we're like, oh, my God, what an emotional roller coaster of the last 6 hours, but we're fine. I still went and they examined me and it all looked fine. Went in the next week to get the wisdom tooth removed and the cyst drained. And then they got in there and realised it's not a cyst. So the biopsy result came back as a super, super, super rare cancer, like as in less than 1 in a million cases. And the people that do get it are normally over 75 and had smoked their whole life. And I've not even ever touched a packet of cigarettes, let alone smoked one. So it was a bit of a shock. I mean, at 34, with 2 young kids, I never, ever thought I'd have cancer. I thought maybe they'd say to me, you can have some root canal or you need a bit of a filling, let alone cancer. But I did know this super rare cancer was actually one of the only cancers that occur in the mouth and head region that has a good prognosis. So I had everyone telling me, the surgeons and the specialists around me saying, look, you're going to be okay. Everything's going to be okay. It's going to be a really rough 12 months, but you're going to be okay. And I was so fortunate to have that because I know most people don't have that. And even when I was stuck in the hospital where I ended up for a really long time, I just had that in the back of my mind. Don't get me wrong. I had many tears every day and many this isn't fair. Why me? But also I could say, look, I know I'm in a privileged position where I'm going home from this hospital and there will be people who don't. So it was that.
Oh, Michaela, there's so much in there that I want to tease apart because we put our faith in this system. And I often joke about doctors with the greatest love and respect because I work with them every day, that they are just taking their best educated guess. And I don't say that to scare people, because I don't want people to hear that and go like, oh my God, nobody knows what they're doing in this universe. But that's the truth, right? So you're saying that you've gone to the dentist has picked this up, you're a doctor, you had thought nothing of it. Then they take the scans, you panic, then they're like, everything's cool. And then it wasn't cool. And so that just drives home even more the fact that we, as our own advocates and next of kin, so the people that love them, have to be in the driver's seat when it comes to our own health, because nobody knows our bodies better than us, our bodies and our minds better than us. That to me is like unequivocal evidence of the fact that, yes, put your faith in the system, but if you feel like something's not right, and I appreciate that this was not that setting necessarily, you have to keep pushing. You have to ask for the tests. You have to ask for more people to review them. You have to know that you can ask for a second opinion. What was that like for you, sitting in a hospital as a doctor, as a mother, going, I'm being told that I'm going to be okay here, but I was also told that everything was fine and that it was a cyst and that it was nothing to worry about. Was there a part of you that's like, I don't know that they got this?
Yeah, 100%, a huge part of me. And also further to that story as to why I ended up in there for so long. I was always told the removal will be okay. It's the reconstruction. So for anyone listening, it was on the roof of my mouth. And so surgery involved, without getting too graphic, removing half of the roof of my mouth and the back part of my upper jaw. And so it eroded through the roof of my mouth and into my sinus. So sort of essentially they had to create a big hole between my mouth and my sinus and then plug it back up. So the removal was always going to be fine, but they said the reconstruction is really, really tough. And so they used a piece of my muscle. They ended up using my thigh to rebuild it. But they'd said initially they tried to use a different part of my body and plug it all in. And they said, look, it'll work. It'll be fine. I was like, what if it doesn't? What if there's things wrong? And they're saying, look, you're young, you're fit and healthy. You're the perfect candidate. It's going to be fine. Anyway, removal went well. 3 weeks later, I had to go in for the reconstruction. Had the reconstruction. It was horrific, but it was as expected. If it's not going to work, it doesn't work within the first 48 hours, which is why they keep you in intensive care. That's just how it works. 48 hours passed, everything was looking great. Then on day 5, mine failed. My reconstruction failed, so I've got a clot in it, which again is unheard of. They rushed me back to theatre, tried to rescue it. They thought they did, plugged everything back together. And then when I was in recovery, I remember looking at the surgeon. I was coming out feeling like they haven't made any more cuts. They must have saved it. Like, this is good. This is good. But the surgeon wasn't smiling. I'm like, why isn't he smiling? This was like best case scenario. They've fixed it. He's like, we fixed it, but we don't know if we fixed it enough. Right. So we sat there for another week watching it, which I was sitting there it's a day longer that I'm away from my kids. And I'm like, why is this happening? Like, I got the rare cancer. I got the 0.01% complication. And like, this is shit. And then on day 7, they were like, nah, it's completely gone. We have to go and do the whole thing again. And each of these surgeries are like 8 hours long. So they're not little. So I ended up having it again. So yes, there was part of me going, have they got it or have they? Because every step of the way, I had an issue. Since coming home has sort of been a thing in the back of my head where I try and let rational brain take over, but it's like, I was the exception to every rule. How do I know I'm not going to be the exception to the rule of it not coming back or of it having a good prognosis? And that's something that I can't say I'm necessarily on top of now, but with time, hopefully, you learn to live with it. Otherwise, it's going to be a bloody long rest of my life if I'm constantly going, is that it? Is that it? Is that it? And again, it's where you also just have to trust the health professionals around you. And going back to what you said about, no one knowing your body better than you, it would make our life as doctors so much easier if we were all robots. And it was just a case of programming and, you run the test like you do on a car and you're like, oh, here's the problem, here's the issue. But we're not, we're humans and every single individual is different. And as a doctor, we make our decision on evidence. On what science, on, pattern recognition. And we go, the statistics tell us that 90% of the time with these symptoms, with these tests, with these whatever, this is what the answer is going to be. And we have to go with that. Yes, 10% of cases then might be different or whatever the percentage might be, depending on the condition. But as a doctor, once you walk out of our door, we don't know what happens beyond that. We don't know how you respond to treatment. We don't know whether it gets better. And that's where, as an individual, we need to then go back and say, hey, this didn't work, or hey, this is still happening, or hey, this has changed, so that then we can start looking into other possible cases and causes and that type of thing.
Would you say that the way that you treat your patients has changed, either through the lens of having lost your mum, and I appreciate that you weren't a doctor yet when you lost her, but how has that impacted the way that you treat your patients, as well as this kind of monumental health journey and diagnosis of your own? Have they changed the way that you treat patients? And if so, how?
I would like to think that I've always tried to be there for my patients and tried to be as empathetic as possible and tried to understand. But I do think when you've been through something personally, it just adds a whole another element to that. And, I am vulnerable with my patients. I tell them what I've been through, within reason and where it's appropriate. But if I'm expecting someone to sit there and be 100% vulnerable with me and tell me the most intimate details of what's going on with them, I need to give a little bit in return. So I think even me going through what I've gone through, when I'd been through what I went through with mum, that I think put me in a reasonable position to do so. And then my experience has just reinforced that. But certainly from my experience with mum, like I said, with myself, I was so fortunate that I had incredible people around me advocating for me. And I was probably my own worst enemy, because as a doctor or a health professional, you kind of want to be the good patient. You don't want to be that patient that's whinging. You don't want to be that patient saying there's something wrong. So I'd just sit there and go, no, it's fine. Yeah, everything's fine. The surgeon would come in every day and say, how are you feeling? Oh, yeah, I'm feeling fine. No, I'm good. I'm really good. To the point where my husband used to come in and make sure he was there when the doctor was there. Or if my husband couldn't be there, my friend, who was also a doctor at that hospital in a different area, would sit there and go, no, she's not. She's actually not okay. This is what's going on. So it does come down to having those people that can advocate for you. That's where I say to my patients day in, day out, you know your body better than anyone. Just because the tests are normal doesn't mean there's nothing going on, or just because this medication doesn't work, or we put you on a medication doesn't mean that's the end of it. If you don't feel right, tell me, and we will keep searching. Even if at the end of it, the ultimate diagnosis is, oh, it's stress related, because we hear that time and time again. Oh, the doctor just told me I was stressed and da. We need to work out why you're stressed, and then we need to try and get to the bottom of it and try and fix it for you. Because if it is stress, it's still causing you physical symptoms, or it's causing you this condition. So I think that experience has really shaped how I approach my patients and my practice.
Oh, I wish all GPs were like you, Dr. MICHELA Sorensen. I do. The world's a better place with you in it. I'm really glad that you're here.
Thank you. You're too kind. But no, and I mean, Casey, I think the more you talk, I'm like, you would be the perfect GP for that reason. It's that advocacy. And I think there are many wonderful colleagues that are out there doing the same and really trying to change the experience people have with their GP.
Thank you. Thank you so much for your generosity. I'm sure that everybody listening will have gotten so much out of that.
Thank you. My absolute pleasure. And it's always a joy to talk with you.
You too. Okay, team, that was a big episode. I really appreciate you taking the time to listen to that. Do me a favor, share this episode with someone that you love. Do me another favor, book in to go and see your GP when you're well, get that health check. Let's get some of those offense and defense players working together to help deliver better longevity, better health, better happiness, more time with the people that we love most. If you are listening to this on Apple Podcasts or Spotify or any of the other platforms, please know that the original home for these is nextofkin.substack.com. Over there, you can join a community of people that are having a conversation about how we can all take better care of ourselves and the people that we love most. You'll get weekly or fortnightly emails from me, only ever stuff that I think is going to lend value to your lives. You can be a free member. You can also be a paid subscriber, which for less than the price of a coffee a month helps me reach more people with the work that I do. I can't thank you enough for taking the time to listen to this. That's what being an advocate for your own health is all about. It's about investing time and energy to protect your most important asset. and make sure that you get as much of our most precious resource, that's our time, on this planet with the people that you love as humanly possible. I'm so grateful to you for being here, and I will see you on the next episode of Next of Kin.
This podcast is presented solely for educational and entertainment purposes. It is not intended as a substitute for the advice of a medical or qualified professional.